Well, thank you, George, and I want to start by thanking all of the supporters of the CARES Conference and the hardworking people whose efforts make this conference possible. This is such a unique opportunity for us to talk about some of the issues in glaucoma that we may not be focused on when we see you for an office visit. And I think a good example of that is the OCT test. When we see you in the office, our goal and our focus is to manage your glaucoma, and we use the test for that end. And in doing that, we're mostly talking about the results of the tests and the implications of those results on your care. But we may not be spending a lot of time talking about why we get those tests in the first place and the interesting science and theory that underlies this high-tech equipment we have at our disposal now in glaucoma. So I want to talk to you about the O.C.T test. And if you or your friend or family member have glaucoma, then you may have already received an O.C.T test, or you may be going over one at some point in the future with your eye care provider. An O.C.T test is called an optical coherence tomography. And like many issues in medicine, to really understand the O.C.T test, we have to start with anatomy and understand more about how the eye works. If you use a camera like an analogy, the eye is like a camera, in that when an object emits light rays, those light rays travel through the lens system of either a camera or your eye, and they're ultimately collected in a camera by film, and in your eye by a specialized living tissue called the retina. And so that retina captures the images that you see, sort of like images in a camera are captured by film. And then the optic nerve transmits those visual signals from the retina, from your eye, back to your brain. And so if we look a little bit more closely, the retina is in the back of the eye. And if you see my arrow here, if you're looking at a vision chart, the light that's emitted by that chart is focused by the lens system in your eye to the back of your eye, where the retina lies. And then the optic nerve comes from the back of the eye and goes back to your brain. And if we look at a blow-up of the optic nerve here, you'll see that it's also a living tissue that has its own blood vessels, and it looks like a cord. And when the optic nerve runs back to the brain, in this image, we're looking at the underside of the brain. So you're looking as if you're looking from the feet up into the bottom of someone's brain. And you'll see that here we have the eyes, and that from both eyes, an optic nerve traces back to the underside of the brain where it meets in a special cross we call a chiasm. And then it carries back into the brain where those visual signals that came from the eye chart to the retina through the optic nerve can then be interpreted by your brain into what you see. The optic nerve, though, is not just a solid cable. It's actually a collection of 1 to 1.2 million nerve fibers coming from the retina. And if you look at the retina closely, it's not just one big orange tissue. It's actually made up of a bunch of fibers. And in certain conditions, you can see those fibers really nicely highlighted. And those fibers descend through the retina, and then they collect into the optic nerve. So you can see that this optic nerve is not a solid tissue, but it's like a cable or a rope that's made up of many, many different nerve fibers. And if you look at this picture of the retina, which is a drawing, you can see that the whole retina is an elaborate network of these fibers, and they're all coming towards the optic nerve to make up this cable. And the way they enter the optic nerve is some of them enter the outside of the optic nerve, and some enter a little more central and a little more central until you get to a point where there's no more nerve fibers. And in that area where there's no more nerve fibers, we call that the optic cup. So the optic nerve is a little bit like a donut with all the important tissue, all those fibers coming in from the outside to a point in the center where there's no more fibers. And that's sort of like the donut hole. We call it the optic cup. And what happens in glaucoma is that those fibers are damaged and we lose those fibers. And as we lose them, that donut hole, that space in the middle, gets bigger and bigger, and all that important tissue in the rim may be lost. So if instead of looking at the optic nerve from the side, we look at it from the front, this is a picture of what the optic nerve looks like when your doctor is examining you. So we're looking at the optic nerve. These red lines here are actually blood vessels coming from inside the optic nerve. And this lighter shadow right in the center is the optic cup. That's where there's no more of those nerve fibers. All the important nerve fibers are out here on the rim, and at some point in the center, there's no more nerve fibers, and that's called the optic cup. This picture's blown up, but that optic nerve that we see in the back of your eye, that front face of it, is about 1.8 millimeters tall. When you have glaucoma and we lose the substance of those fibers, we're losing the substance of the optic nerve, and you see this donut hole in the center is much more pronounced in this case. But there's still nice, healthy orange tissue along this rim, so there's still donut here, but there's a bigger donut hole than in this normal picture. And in very advanced stages of glaucoma, the optic nerve is like a shell, where all the important tissue is gone, and that donut hole has taken over the entire donut. The theory that underlies the OCT test is one of form and function. So what we believe in glaucoma is that you succumb when you have glaucoma to changes in the structure of the eye, specifically in the structure of those nerve fibers and of the optic nerve, and that ultimately results in a change in your function, which is your ability to see. So the structure changes before you have a change in your vision. The way that cascade works is that when the pressure in the eye is too high for a particular eye to tolerate, you get damage to those optic nerve fibers. So if you look at a blow-up of the drawing that we saw before, where all of these intricate nerve fibers are mapped out in the retina, this dark area is meant to represent a place where those nerve fibers have started dying out from glaucoma. And then, as they trace into the optic nerve, you can see that there's a bite out of that donut. There's an area where those fibers come in, and that donut tissue is lost, and the donut hole has gotten bigger. And if we look at a picture of a real optic nerve, that same phenomenon is happening here. But you'll notice you can see that the optic nerve is different, that there's a bite out of the donut down here, but the retina still looks orange, just like it did before. So it's very hard for your doctor to tell that there's changes in these fibers, but relatively it's easier to tell that there's changes in the optic nerve itself. And so when those optic nerve changes occur, they can lead to vision loss from glaucoma, and that's what we want to prevent. What's important to us and new and different about the OCT is that we're trying to break this cascade. What we want to do is find problems with glaucoma occurring earlier and earlier, because when those fibers are gone, we can't get them back. So we want to identify any changes, and our goal here with the OCT is to see the changes in those fibers before they ever pop up as a change in the optic nerve that's easily identifiable to us. And so we're trying to break this cascade here between damage to the optic nerve fibers and the optic nerve cupping that we can see in order to detect glaucoma and glaucoma progression earlier and earlier to prevent ever getting to the point where vision is lost from glaucoma. So that brings us to the OCT. As I showed you in that picture, we can't really see a big change in the retina most of the time when those fibers are being lost. We have to wait until it gets to a change in the optic nerve, or at least we used to have to wait. Now we have a test that can measure the thickness of those fibers and identify when those changes are occurring before we ever see them on exam as a change in the optic nerve itself. OCT is called optical coherence tomography, and it's creating a digital model of the structure of the back of your eye. Now, I bet many of you have heard of a CAT scan or a CT scan. That CT stands for computed tomography. Tomography is like mapping, basically. And the computer is, because we are using so much data, and we're amalgamating or collecting all of that data to form a picture. So if you take an X-ray, it's one set of data. If you take a CT, it's many, 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 many X-rays that come together using a computer to make a picture. And likewise, the OCT is sort of like a CAT scan or a CT scan of your eye in that it takes a computer and a whole bunch of data in order to make one really detailed picture. But an important difference between the CAT scan and the OCT scan is that the CAT scan uses X-rays, which are radiation. And the OCT scan does not use X-rays. It does not use radiation. It exposes you to no radiation. It's just infrared light. Now, part of what's important, and this gets a little sciencey and complicated, and we're talking about physics of light here, but the way that the OCT identifies what changes are occurring using light is by waves. All light occurs in waves, and some waves, if they line up just right, they may add together to make a big wave. So two waves that are in sync with each other may make one really big wave. And likewise, two waves that are out of sync with each other may cancel out to make no wave at all. And so if we look at a really detailed picture of how those waves are adding and subtracting, then we can make a determination about what's going on in a tissue. This is an OCT machine like you might see in the office if you get a test. And what that piece of equipment is doing in a really basic analysis is it's shooting light at your eye, and that light, as it comes through the machine, is being split. So that part of it goes to a mirror and part of it goes to your eye. And when that light bounces back from the mirror and from your eye, there's differences in those waves. The light that went to the mirror just comes back like it left, and the light that goes to the eye has some waves that might be out of sync with the waves from the mirror, and they subtract, and other ones that might be in sync and add. And if we look at a detailed analysis of that pattern with a detector, then we can ultimately make a picture of what's going on in the back of your eye. So when we look at you with that OCT machine, we're picking up an image. This is an image of the retina. And what's amazing about the retina is it's multi-layered. You can get a sense here for there are many, many layers in the retina. And this particular picture shows a valley. That valley is right where the spot in the retina called the fovea exists. And the fovea helps you with your 20/20 vision. But in glaucoma, we're not so interested in the fovea as we are interested in the tissues, those fibers that are right around the optic nerve, because we're trying to find changes in those fibers before they cause cupping of the optic nerve that we can see. If we look at a printout of the OCT, when we collect that information on those fibers, the machine compares your information to people who are your age but do not have glaucoma. And it gives us some reference of how likely it is that your results are normal. And I want to go through an OCT printout here. This study is from a patient, myself, and it's a normal study. So this is sort of a baseline for what the OCT should show. The first part of this printout is a picture of the optic nerve. You see it in black and white here where it was in color when I showed you the orange with the red lines. These lines here would be red, this tissue is the retina, which would be orange, and this optic nerve is right in the center. And you see that this circle indicates the fibers that we're measuring with our OCT study. So we were measuring those ones that are coming from the retina, but they're right around the optic nerve. And when the computer analyzes that data, it gives us a picture of how thick the retina is, and it can isolate certain tissues you see highlighted by these red lines that are within that multi-layered retina. And then it can analyze all that data to give us a graph that shows us how likely it is that your results are normal. So when we see here, you can sort of make out there's a green line that's running in these humps. That's the average in what we call the normative database, or the machine's pool of people who are your age but don't have glaucoma. That's the average of the thickness of their nerve fiber layer tissues, their retinal fiber tissues. And if you're somewhere in the green here, the odds are that your results are normal. If you get to the yellow, you may be normal, but the odds are you might be abnormal too. And if you get to this red bar here, where you're way out of the green zone, then it shows that the odds that your results are normal are very, very slim. And so that's helping us make comparisons to identify glaucoma. I showed you that circle in the picture initially, and these are number points or data about what the machine found in that circle. These numbers represent microns. That's microns of thickness of the nerve fibers that make up the optic nerve. And a micron is 1/1,000,000th of a meter, 1/1,000,000th. So these are very small amounts of data that we're able to collect. And if you look at these numbers and we follow these over time, we can identify when these numbers are changing, and we hope that that helps us pick up changes in your nerve fibers that indicate worsening glaucoma before it ever manifests as something you or your doctor would otherwise notice. Incidentally, the machine also helps you compare one eye to the other, so it gives you graphs of both eyes to show how thick or thin the tissue is in one eye compared to the other, because sometimes glaucoma may be worse in one eye than the other, and it often starts out as worse in one eye than the other. So it can give us an extra clue that something is changing in one of your eyes. These are some number points from those same circles, but in a patient who is abnormal compared to their age-matched controls. So you can see that in these wedges, here this patient was red, here this patient was red, but in these spots they were green, and that's actually a very typical pattern that we see in patients who have glaucoma. And if we break the data down further into little clock hours, some areas are sort of borderline, some areas are clearly abnormal, and we follow this over time to help us determine what's going on with your glaucoma. So to summarize, the OCT provides us extremely detailed information about the retina and the tissues that make up the optic nerve. And our goal in glaucoma is to try and identify changes in form before they ever get to the point where they change your function, where they change your vision, and then ultimately your ability to do the things that you want to do, which are visually demanding. The OCT may identify changes in the fibers that make up the optic nerve before your doctor can see that those fibers are changing. And that way it provides us an extra leg up in advanced diagnosis and management of glaucoma. And we hope that the OCT will help us prevent you from ever getting vision loss. But it is important to note about the OCT that what we're really trying to determine is what kind of change is clinically significant. When you have a change, how do we know that that change is enough, that it's worth the risk of an intervention like another medicine or a surgery? And that's the information that we are still actively trying to work out with our glaucoma research. And I think that and hope that with this powerful tool and all of this data, as research progresses, we'll have better and better ways to analyze all of that information to help us understand your glaucoma. Thank you. Any questions? Please.
Do all doctors' offices use the OCT machine?
You know, I focus on the OCT because it's one of the newest machines. I think the answer is probably no. Not all offices have the OCT, and not all offices may have the same OCT machine. But the OCT is an example of a larger field of study, where in the OCT we have a specific technique for measuring the tissues around the optic nerve. But we in our office for many years have used HRT as well, which is another acronym for another machine that's trying to do the same thing. And GDX is another acronym for another machine that does the same thing in an even different way. So there are a lot of machines out there that are part of this goal to identify changes earlier and earlier. So not all offices have the same machine, but many offices that are following glaucoma are using these types of equipment.
For someone with moderate, maybe severe glaucoma, what's the suggested frequency of doing this exam?
I think the short answer is debatable. We don't know, and to some degree all this has to be individualized based on your clinical picture and how suspicious your doctor may or may not be about you changing. We think that the best utility of the OCT probably lies earlier in the treatment algorithm. So we talked about that we're trying to pick up these changes before they result in a change in function. Now, a change in function may be vision loss from glaucoma, and vision loss from glaucoma we might identify with, for example, a visual field test. So in a broad perspective, people who have really early glaucoma may not have visual field defects, and we could get the visual field many, many times, and it might just be normal every time. And we want to get it, but maybe with not as much frequency as we might get an OCT, where when you don't have any visual field defects, changes in the OCT might be more valuable. Later on in the algorithm, we're really interested when your function is already changing and mapping out any changes in that function, and we might skew our testing more towards visual fields. So that's a broad perspective, but in short, it has to be individualized. Let's go around the room.
Has this OCT test been in existence?
That's a great question. It's been in existence in various forms for 10 or more years. However, the OCT pictures that I showed you are from a newer type of OCT machine, which has really been only in active clinical use for a few years. And that's part of the reason we don't have all the answers from a research perspective. And it's in some ways a really good problem to have. The technology is advancing so fast. that the machines we have now give us exponentially more data than the machines we had just years ago. And the research hasn't quite caught up with the new machines to help us use them to their full potential. So both the brand new machines and the machines from 5 years ago provide really important data about following glaucoma. And our hope is that as we get more and more information, the research will give us more and more ways to use that information.
Well, if you are already full-blown glaucoma, is this helpful?
The question is, if you already have full-blown glaucoma, how helpful is the OCT? And a lot of the research shows that when there's enough thinning in those nerve fibers, that measuring small changes probably isn't of huge value. But like I said, the process is always evolving and ongoing, and we don't know exactly how the data will be analyzed in the future. So I think it's reasonable to get the testing in people who have advanced glaucoma, but our ability to harness those results for really active clinical management may be more limited than in patients who have earlier glaucoma. In the back?
Yes, I would like to ask, I come down and all this filming is done of my eyes. Is that included in this OCT? I mean, I'm going to ask the doctor the next time I come. I'm just curious, since there are so many pictures taken.
Sure. I know it gets confusing when you have so many things you're doing at each doctor visit, and it may be hard to know exactly what the acronym is for a test that you're taking. If you have glaucoma and you're actively managed for glaucoma, oftentimes either the O.C.T test or something that is similar to it may be included in your evaluation. But it really is all individualized, and it depends on how you're doing. And so I think the best thing to do is exactly what you said. When you see your doctor, ask what test you're getting. And you can ask if the OCT or another test like it is part of your follow-up course.
Well, I don't have glaucoma, so that's why I'm not sure.
This test is often not included in a typical comprehensive eye exam.
Okay.
So it's more specific for glaucoma. Now, it's not only used in glaucoma. It may also be used in problems of the retina. And so there are other reasons to get an OCT besides glaucoma. We've obviously focused on the glaucoma applications today.
Thank you.
More questions?
What is the test that, the only thing I know to refer to it as the blue light when the doctor shines a blue light into your eye?
So I think what you're referring to is actually measuring the intraocular pressure. The question is, what's the blue light? And if you have glaucoma or you've had an eye exam, you're probably familiar with the blue light. It's on a little pointer and it comes very close to your eye. And that's called applanation. And that helps us measure your pressure. And what we are essentially doing is we are impinging or pushing on the cornea just a little bit and seeing how much the cornea pushes back. And that there are mathematical principles that allow us to make assumptions on what your pressure inside the eye might be by pushing on your eye a little bit. So that's what that tool is all about. Other questions?
What's the most accurate way of measuring pressure? Is it the pop test or the one with the other instrument?
So for many years, the answer to that question has been the applanator, the blue light that comes at you. However, there are newer versions of the puff test that are more sophisticated than the puff test that we used many years ago. So the gold standard for pressure measurement has typically been considered Goldmann applanation tonometry, which is that blue light that's on the microscope. However, there are new machines that are coming out that are doing really sophisticated analyses of the puff test, where they're measuring when a puff of air hits your cornea, just how flexible your cornea is, how much it moves back and forth, and we'll see over time whether that information ends up being more valuable than the Goldmann test. So the Goldmann is still the gold standard, but that doesn't mean that that's the only accurate way to measure your pressure.
How long have you been using this new OTC test?
OCT test? Usually, it's been in clinical use for the last few years. It depends on your doctor's office whether they use this one or the other one, and there's great research to support the value of the one that came right before this one. So I think that's a very valid test and a good one to get. And we'll see over time how dominant the machines become based on the research that underpins their use. So it's a matter of a few years. Any other questions? Thank you very much.